The subtalar joint arthrorecess implant system allows minimal incision insertion of a subtalar joint arthrorecess implant. The MetaSurg set comes with 5 color-coded trial sizers matching the 2 actual implants that come with the set. They are number scored for ease of insertion. The driver also has a tapered end to allow for ease of insertion and will not allow the implant to stick to the driver once the implant has been seated properly. The set also has a unique removal tool which makes it easy to remove an implant should one be necessary to do so. The removal tool is utilized in a counterclockwise rotation method, so if the implant is in the subtalar joint and needs to be removed, one would pretty much just reverse the screw, insert it over the removal tool and remove the implant out. A sinus tarsi dilating probe and guide wires are also available for ease of insertion. The implants are also numbered from 8 through 12, corresponding to their color-coded implants of the same diameter. Each implant set comes with 2 sterilized sizes of implants. The subtalar joint arthrorecess procedure is primarily indicated for a frontal plane dominant flat foot correction. In this case, this is a 12-year-old female with a flexible collapsing pes plano-valgus flat foot, which has been causing her progressive pain with increased ambulation and sporting activities. The subtalar joint arthrorecess is implanted through the sinus tarsi canal, which is most easily accessed through a lateral approach. The sinus tarsi canal can be presumptively found approximately 1 centimeter anterior and 1 centimeter distal to the lateral malleolus. If there is any question as to locating the sinus tarsi, one may utilize a 27 gauge needle and insert it from lateral to medial in through the sinus tarsi canal. A larger bore needle may allow extrusion of synovial fluid, confirming entrance into the sinus tarsi. Once the sinus tarsi has been located, a 15 blade may be utilized to perform a 1 centimeter curvilinear incision over the sinus tarsi. The incision only needs to be the width of the actual implant, which may at most be approximately 1.5 centimeters. This procedure is done without tourniquet control with the use of adequate local anesthetic. Tourniquet control is not necessary in this case. Also suggested to do this procedure in a prone position, which if adjunct procedures are necessary, may allow for easier access to the anatomical locations. Once the incision is made, the capsule structures may be pierced with a guide wire and the sinus tarsi canal entered from lateral to medial. The guide wire only needs to be inserted till tenting is noted inferior to the medial malleolus. A dilating probe is then utilized to dilate the sinus tarsi canal, which is subsequently passed over the guide wire and turned in a counterclockwise or clockwise motion. In doing so, one dilates the sinus tarsi canal for increased ease of insertion. Following dilation of the sinus tarsi, subsequent trial sizers may be utilized to determine the optimum level of correction. At this point, we are going to try the number 9 trial sizer and insert it over the guide wire in through the sinus tarsi canal. Notice the laser marked scored numberings on the trial sizers. This will be helpful in knowing and helping the correct distance to place the actual implant post trial sizer procedure. The foot is then manipulated through its range of motion. And may be confirmed via fluoroscopic guidance as well. Okay, let's get the fluoro in. Note that a curvilinear incision was made parallel to the neurovascular structures. One may also use a transverse incision parallel to the relaxed skin tension lines, We do know that the two major structures to avoid would be the sural nerve coursing inferiorly and the dorsal cutaneous nerve coursing superiorly. With a curvilinear parallel incision site, the two important structures are less at a chance to be transected or damaged. We utilize image intensification to allow us to determine the optimum position of the subtalar joint implant. Proper placement of the subtalar joint arthroeresis should allow the leading edge of the implant to sit in the middle third or optimally the center portion of the bisection of the talus. Once the appropriate position is confirmed, we can then utilize the actual subtalar joint implant. Utilizing the guide wire in its proper position, the trial sizer is then passed and removed over the guide wire and away from the operative field. At this point, the optimum corresponding implant is removed from the surgical tray and the size and color are confirmed. The implant is then passed over the guide wire and seated in place with the implant driver. The implant driver is subsequently passed over the guide wire, locked into the implant, and it is inserted to the predetermined depth on the implant driver. Optimum positioning of the subtalar joint implant should allow the leading edge to bisect the center of the talus. Once we are happy with our position under fluoroscopic guidance, the guide wire may then subsequently be removed and the insertion tool may be then used to increase the depth or decrease the depth of the implant as we deem necessary. Once we are happy with the overall placement, the insertion driver may then be removed. The benefits of the subtalar arthroeresis procedure outweighs significantly that of an arthrodesis procedure in those patients who have healthy, non-arthritic cartilaginous surfaces, allowing correction of the abnormal range of motion but preserving the normal range of motion allowed in the subtalar and ankle joints. Upon completion of the procedure, the foot is manipulated and noted that the excessive pronation has been corrected. Standard closure is followed with capsular suturing followed by skin suturing. The patient is then placed in a below-knee weight-bearing to tolerance boot for 2 weeks and subsequently transitioned to a tennis shoe as needed. If adjacent procedures have been performed, additional partial or non-weight-bearing time may be required.